Hi, I'm Dr. Bohn.
I'm Dr. Tartaglia. Today we're going to bring to you a talk about the significance of falls.
So if you go back to our videos, how can I tell if I have a serious illness? Falls are one of the things that we listed, and one of the things that we talked about, and it's a huge topic. And so today we're going to expound on that just a little bit. Now we're not going to talk about falls in environments like loss of consciousness, a stroke, motor vehicle accident, an act of violence causing a fall, or a fall during a sporting event. Our falls that we're talking about more are homebound falls of individuals and institutional based falls of individuals.
These falls that usually occur with frail patients, and it's a sentinel event.
Sentinel event is like a landmark event or a very important event at a hospital or facility. And so if somebody has a sentinel event, whether it's a fall or when we can talk about other sentinel events in a different video, a big investigation occurs.
There's an increased burden to the patients depending on the cause of the fall, also to the healthcare system, burden to cost of the fall, to recover from the fall, and also it creates a huge burden to families, both not only just financially but also mentally. They get very concerned as to why their loved one is falling and what they can do to prevent the future falls.
If an individual is frail, particularly if they're frail and elderly, the risk is significant for injury from fall. Anybody over the age of 65 is at higher risk, and of course the greater the age, then the higher the risk of injury is for fall. In 2016, it was the third fastest growing contributor to death rate. And you know, we know that as the population does age, we know that those risks are going to increase. Injuries that can occur from fall will take a person to the emergency department, and in fact it's one of the 4 top causes for many emergency department evaluations.
When we're talking about injuries to the fall, we have to look at did the patient have any abrasions, which means scratches, it's a formal name for scratch, or contusion. Did they fall and did they fracture a bone? A big bone such as the femur or hip fracture is really significant. Even wrist fractures can be the demise of patients if they fall on their outstretched hands. They lose the mobility to feed themselves, to dress themselves, and this creates a lot of havoc to their system because they already were slightly debilitated, and this might cause their debilitating illness to progress suddenly. Pelvis fractures are also very significant, and then the fatal, or the big word, head injury. We hate seeing those because we just sometimes don't know the significance of them initially. They may manifest over the next couple of days to weeks.
So any of those falls that may result in a fracture impairs immediately, but then it may start this decline that occurs over time where a patient is not as functional as they once were, they're not as ambulatory as they once were, and so that those injuries from falls are significant and to damage to the patient, and they are very costly to the system. Inpatient injury falls may total a cost up to an institution of $250,000 in a year. Costs related to falls for the hospital system and the healthcare system totaled $50 billion in 2015. So we've got to try to minimize falls, particularly in institutions and in hospitals.
Yeah, and there's common locations for falls. They do normally, they can occur, as Dr. Bohn just said, in the hospital. They can occur in an independent living facility, in an assisted living facility, in a nursing home, in a rehab. Most institutional falls do have policies in place, but as long as there's humans involved and multiple people involved in people's care, unfortunately, it's not 100% of a safe place, just as the falls that occur in the patient's home. Institutional falls take up 40% of the fall rate, which is quite high.
Significant. If a person experiences a fall, falls are typically a marker for frailty, immobility. They can indicate that a patient has a shorter life expectancy, and it indicates or leans into a significant burden to that person from acute or chronic illness.
Yeah, it's interesting that you mentioned that, Dr. Bohn, because how often do we meet patients? As you all know, we do hospice and palliative medicine, so we meet people after they've had the fall. And a lot of times people are like, oh, my loved one was, going bowling and golfing. I mean, where we live in Florida, golfing's a big one. They were able to golf 9 holes, sometimes 18. They went out to dinner with friends, and now they're bedbound and they had a hip fracture or even, a mild head injury. And we have to kind of put all the pieces together to explain to the family that this was probably, that sentinel event was the fall. And it's very sad that it causes someone's demise.
And sometimes we can't really tease out, did they fall because of their weakness and their illness, or did the fall cause them to become more weak because they were less mobile, and then decline occurred after that?
Yeah, and it's hard for us to tell because a lot of times in our more functional patients, they may have been masking all these underlying cardiac issues that could have caused the fall, pulmonary issues, and they were just, they were giving themselves the cardiac stress test every day, going out, playing golf, doing other things that you do not know that all these underlying illnesses could have affected it.
So there are patient factors and facility factors that put a person at risk for a fall. So let's talk about some of the patient factors.
Sure. Posture.
If a person's posture is kind of off, I know a lot of patients, a lot of people after, a certain age, maybe their posture, they're bent a little bit. I know I feel bent some mornings more than others, and at the end of the day, I may straighten up during the day, but I know at the end of the day, my posture is also not so great. Well, that changes your center of gravity.
And that will also make you fall. Vision changes will also.
Oh my gosh, I've got several pair of glasses, and some of them I see better close, some of them I see better far, and some I feel like I don't see well at all. I like wearing contacts, but if I wear contacts, I cannot see close. So vision is huge, and for somebody with, mild to moderate cataracts, maybe they don't qualify for surgery yet, they don't see the colors well. I know I've had comments from patients in the past after they had cataract surgery. One lady told me it was awful. She said, I had no idea I had this many wrinkles until I had my cataract surgery. So it's one of the worst things I've ever experienced, just to look at myself in the mirror now. And I've had other patients tell me that, once again, tree leaves are green and white is stark white and beautiful, because they did not realize over time how dim their vision had become. So vision is really key, really important.
Yeah, and I think, like Dr. Bohn said, a lot of times people don't realize how obscured their vision is until they have a fall or they have a repair of their vision. For myself, I have one pair of glasses, but they're progressive. And so at different times of the day, I have to move my glasses to see. So if you're immobile and you can't even move your glasses, I can't imagine what that's like. Another contributing factor is breathing.
So if a person is short of breath and, they take a few steps and they're not breathing evenly, or maybe they're using supplemental oxygen and that limits their ability to be mobile, that could cause a fall if they've got, tubing on the floor or if they're winded easily.
Yeah.
So let's talk about fatigue for a moment.
Yeah, oftentimes patients and people that are compromised do not realize how tired they are and how much energy it takes even to get out of the chair. So their fatigue may be so overwhelming they can't even it takes exorbitant amount of energy to even come to a standing position, which then will cause them to fall.
And that's part of strength,
Yes.
I call it using your front legs to help your hind legs.
And a lot of times, a lot of patients will overcompensate with their front legs, meaning their arms, and they will lose their center of gravity and balance and fall.
What about an abnormal gait?
Oh, well, that plays a huge part in falls because patients do not realize that their center of gravity is off, like we've already discussed center of gravity, just in their gait, gait is a fancier word for walking.
Yeah.
And
they shuffle their feet, they drag their feet, they don't pick their feet up and clear very well. And some of that may be just bad habit. There may not really be a good reason for the gait abnormality, and there is gait training that's available.
Right. Or the ones that are supposed to be using devices for their gait and they don't use them.
Yeah, that's a risky behavior.
Yes.
Other risky behaviors might include drinking or other medication or other chemical use, being told you're supposed to sit up and dangle your feet, before you stand, you're supposed to kind of get your bearings. You're supposed to be using a cane or a walker or a rolling walker or a rollator or a wheelchair, and you're trying to shortcut. So risky behaviors can certainly contribute to an individual's fall.
Mm-hmm. And also patients that have joint issues and pains in their joints, that will contribute to their fall because they might overcompensate on one limb versus another and lose their center of gravity and fall.
Or if they get a sudden pain, they're walking and seem to be having no issue at all, and then they get a sudden sharp stabbing pain, whether it's in their back or their knee, that's enough to make them recoil and react, and that can throw off their gait, their balance, and then they can fall from that.
Confusion plays a big role in falls. If their mental status, it could be that they're more confused because they've just had surgery, or they have underlying dementia. It could be worsened. They may have an infection which causes the worsening of confusion. That may be a cause for the fall.
Or if their oxygen level is low.
Yes.
That can cause it. If they've just recently had a TIA or a mini stroke, they might have confusion. And sometimes it seems like confusion can wax and wane. They can be better and they can be worse, almost moment to moment sometimes.
Yeah, sometimes people are better in the beginning of the day, and then towards the end of the day they might have more of this sundowning, which is kind of a delirious state that they go into that may cause them to be worse. But then I have some patients that are pacing at the end of the day. Their gait is even better when they're more agitated.
Yeah. And that, may all contribute to fatigue. Let's talk about body functions for a minute. Let's talk about bowel and bladder. I think those are contributors too to falls.
Diarrhea. I'm trying not to laugh at this, but I have to tell a story.
Okay, a diarrhea story. This will be good.
This is a really funny story, and this is about my family. Is my grandmother, I've shared with you all, I mean, God rest her soul, thank God she's dead. She would kill me with the story, but my family will laugh. We had a summer home at the Jersey Shore, and it's we still have that home. But when she was older and she got around with a walker, it was very hard for her to move and have, she had severe mobility issues. The other problem with that home is it's one flight of steps just to get into the house. So it's, a garage, basement, then you go up a flight of stairs. So one day we're trying to get her out of the car. She loved the Jersey Shore because it was 30 minutes from the casinos, and we're trying to move her quickly, and she starts screaming, "I pooped myself." And we're like, "Grandma, what are you talking about?" And she's like, "I have to go to the bathroom so bad, and your father put these rocks down." So it was an uneven ground. So it caused a lot of gait issues. She couldn't move the walker, and she had to go to the bathroom so bad that she was about to fall. Thank God my brother was there to grab her, and she blamed all of this on my father laying down the rocks. And she had absorbent amounts of diarrhea, and we had a big mess to clean up. But this is a serious issue. I mean, I make light of it now, but it's very funny because in reality, she was used to having concrete to walk across, and because the rocks were there, she couldn't move.
Yeah.
And then she blamed walking on the rocks that caused her to poop herself, which I have to laugh as a physician. That makes no sense. But that was her story, and by golly, we better stick to it. So we all laugh whenever we're stepping on rocks. My brother will turn back to me and say, "You having any problems? Do you have to go to the bathroom?"
So inside family joke.
It's an inside family joke.
Well, if your bowel alarm goes off or your bladder alarm goes off, it's pretty important. You've got to answer that really quickly, because most of us, since we were about 2-3 years old, don't like to soil ourselves, and we want to make it to the bathroom. So diarrhea, bowel issues, bladder concerns, those can certainly contribute to a fall.
And I have to tell you, as a physician, how many times have you been in the room to evaluate a patient? They're like, "I had to pee and I've been on the call bell."
Yeah.
And I get that we're all busy, but my goodness, help the person.
Let's help this person get to the bathroom.
I think it's important to discuss being out of your element when you're in a facility setting, which is not normal to you. The lighting, the flooring, the room temperature, all of those things play a role in the patient's safety.
That's a really good segue into our next thing. Let's talk about facility responsibilities or facility factors as they relate to falls. So lighting is certainly one.
The flooring You know, you shouldn't have stuff on the floor that could obstruct a patient, the room temperature, and then, you know, I think you need to talk about the call light device because you spend a lot of time in the hospital.
So those call light devices, I think, are different at most institutions, and they're really complicated to try to figure out. You know, I was trying to help a patient. He wanted a particular channel on and was looking for particular programming. And there's up, down buttons, and some of them are for the bed control, and some of them are for the television. And then the call light is usually a big red and white plus, and sometimes there's a little emblem of a nurse with a nurse hat on. Now for me, my grandmother was an RN, my aunts were LPNs. I understand the nurse hat. I cannot tell you in the hospital the last time I saw a nurse with a nurse hat. So I don't know why they're still putting that on the emblems, except our population that we take care of at the hospital where I work for is mostly over the age of about 50, 55. They get that. But a younger person, if they looked at that emblem, they're going to understand it, you know, if they see the word nurse, but they're not going to understand what that nurse hat emblem is. That just doesn't make a lot of sense, and those controls are so complicated.
Right, and sometimes it's hard for the patients to find it,
to see it, to press the button.
There's a lot of things that you have
If that thing falls off the side of the bed, it's on a cord, and they pin it to the side of the bed, but they're trying to feel alongside of the bed. Maybe they put it on the side where the patient has neglect from a previous stroke, so they don't even realize it's over there, or maybe it's out of reach, or maybe they have a lot of swelling in their hand, or they've got terrible arthritis and they can't reach the thing. So I see those call light devices as a major issue. I know they've done the best they can, but we got to keep working because they're not good enough.
Yeah. And then you were talking also to me about like layout of rooms, like in a more modern hospital versus...
It's different than the person's home environment, so that can be upsetting and disorienting. And if there's not clear space, so many hospitals now are being built for, you know, one patient, but because of the crisis of healthcare and more patients being elderly and patients needing to go to the hospital, particularly during 2020 and 2021, we had some rooms that were meant for one patient actually had to have two people in it. And I think the hospitals had to get, you know, special permission to put two people in a one-person room. Those rooms were tight with those two beds in there, and there's not clear, you know, space for a patient to ambulate, especially if they need a device. And if we go in with a team, because many times I may have a medical student and or a resident with me, maybe I have a social worker and a chaplain with me, there's not space for all of us in there with two beds, patient, and a couple of families. So those are some of the major facility issues, but let's talk a little bit about a specific part of the facility that's not really the physical plant. Let's talk about staffing. Number one of staffing is the number. How many staff do we have? Are they available?
And I think that's really important because like anything in this world right now, we're all going through shortages in every... You know, you can't go on a flight without a problem. We can't go in the hospital without a problem.
You can't go out to eat.
You can't go out to eat. You're right.
You walk up to a restaurant and there's a bunch of empty tables because they're short-staffed.
And I think it's so important that we know that the responsibility of prevention of falls has to occur between all the stakeholders. It's not just the patients that are responsible. It's the healthcare system. It's the family. We all must take responsibility.
So we don't point a finger of blame, you know, the patient did this, the nurse didn't do that, the family member, you know, there's no fault in it. There's no blame in it. We are all stakeholders and we all take responsibility and we all need to work together. It's just so important for the reduction of falls. Patients have to help themselves. Particularly at home, you know, at home you can make sure you have good footwear on, make sure you've got good lighting in your home, and, you know, if you have to go to the bathroom, I know you don't want to turn the light on in the middle of the night, but you really need to be able to see. If you're supposed to be using a device, you need to use, you know, whatever device that is. If it's a cane, if it's a walker, if it's a rollator, you need to be using that when you're ambulating. Your floor needs to be clean and clutter-free and not slippery. And throw rugs need to be thrown away.
Yes, they're
because
so dangerous.
That's a big trip hazard. Carpet, if it's tattered carpet or if there's a loose corner, that really needs to be tacked down. Electric cords that may run across a path, and I know we see that a lot during the holidays because, you know, people put Christmas lights up or put Hanukkah lights up, and so there may be holiday electrical devices that require power, and we've got to be real careful how the electric cords are across our home.
We also need to be prepared and be willing to admit that we should not be doing unsafe things without other people around.
Are you talking about climbing?
Yes, I'm talking about climbing, Dr. Bohn.
I've promised my family that if no one is at home, then I'm not going to get on a chair or get on a ladder. A few years ago, I was walking early in the morning, because that's kind of my habit, is to get up early in the morning, and I was walking on the sidewalk, and the sidewalk was uneven. And it was, you know, there's street lights out, so I didn't have a flashlight on me. It was, you know, just early morning, not quite bright, not quite dawn yet.
She walks in the dark.
Yeah, I was walking in the dark, but there were street lights on, and I was in my neighborhood. And anyway, I tripped and I went down, and I wanted to put out my hand, and that's called a foosh injury, fall on an outstretched hand. And as I'm falling, I'm thinking, don't do that, you'll break your wrist. And so I kind of turned and rolled, and I sort of landed on my shoulder, but my hand here still took a scuff against the sidewalk, and I kind of even scarred up my glasses a little bit, but I didn't hit my head, I didn't bruise my face or get a head injury or anything, and I kind of rolled over into the grass. And then I got up and I dusted off my pride, and I went on home, and I had to bandage my hand here where I got injured. I think I tore my shirt too, but I had to bandage my hand. Well, a few days later, my family saw the bandage on my hand, and I had, you know, washed my hands, so that wound was open and they could see it, and I hadn't redressed it after washing my hands. And of course they asked what that was from, and
were you truthful?
Eventually I fessed up, and so they decided that I needed to have a device that would alert them when I fell the next time. And so, you know, I have a nice watch that communicates with my phone that the kids got from me, and they set it up so that when I fall, it sends them an alert. And I was at a facility, I was still working in an assisted living facility at that time, and I like to take the stairs when I can to try to stay active. And I was going up the stairs, and I'm carrying my bag that's got about 15 pounds of stuff in it, and I didn't lift my foot high enough for the next step.
No.
So I literally fell up the stairs. Now I just put my hand down hard. I did not go down because the big bag was there.
Thank God it anchored you and didn't pull you the other way.
It pulled me forward, and I put my hand down. Well, the watch went off. Yeah, and it said, do you need 911? Do you need an alert? You have 60 seconds to respond. And then it started this like countdown timer, and so I'm like, oh my gosh, no, don't call 911. It was pretty comical. But I wear that device most every day, and I have never disarmed it. I'm sure I could eventually figure out how.
You better not.
But I will not, because that was given to me by people who care about me and who love me. And so that's just part of the promise that I've made to them. You know, that if I fall, I'm going to fess up, and I'm going to wear the watch, and I'm not going to climb on ladders. I'm not going to climb, you know, on the countertop or anything if somebody is not home. And I've made good on that. So those are just some general risks that you can have. Certainly foot care and dizziness, along with the mobility device that a person might need. Staying strong and being active, limiting chemicals such as alcohol that might impair it. But there's another complicated factor that, you know, patients can help with, and that's medications.
Yeah. Oftentimes there's certain medications that might make you a little bit more loopy, not alert. They may cause you to have dizziness. Some medications make you have to urinate, like a water pill for a diuretic that makes you urinate, and you have to really, really go quickly. So you need to just be aware of your medications, what your reactions of the medications are, and what you can do to help your situation be safer to prevent falls.
And if you're supposed to take a medication, take the medication. But
Yes.
if you have a side effect from the medication, you must impress upon your physician that you do have a side effect to that medication so that they're aware.
Oftentimes patients don't like to tell the physicians their side effects because they think that they're complaining, or they don't want to be scolded, but these are important things that you have to disclose.
There are many screeners that are used, and I think, we're not going to go through all those. The only one that I personally like, because you can do it at home, all you need is 10 feet, a chair, and a stopwatch, is the get up and go test. And that's where you just have the patient seated and you start your timer. They are to stand up on their own, walk 10 feet, turn around, and sit back down. And that should be accomplished in less than 10 seconds. And less than 14 is considered normal, but between 10 and 20 seconds, there is a little bit of an increased risk for fall, and greater than 30 seconds means there's a significant risk for fall. And some people even feel that if their fall risk is high like that, that maybe they shouldn't be leaving the house without somebody with them because that fall risk is too great.
Right. And the good thing about this tool is, we as physicians in the medical field, we have so many tools and tests, and this can be done at home. So obviously with the safety in mind, obviously have a family member with you, but just to have a better idea, because a lot of times family members don't even realize how debilitated their loved ones are.
Right.
Because they do a lot for them.
Well, and you're watching the iceberg melt by just one drop a day.
Yeah.
And so sometimes you don't see how that change has occurred. When we have a patient come in, we do a detailed patient assessment, and it's by trained staff. They are to work in a collaborative manner with other staff members, and it's to be population based. We talked a little bit about the greatest generation and the boomers. Those people are at more risk, and we need to make sure that we're addressing their needs. Safe and timely toileting is probably utmost. Ease of mobility, managing their mobility device, managing their pain, anticipating what their needs are. So they're not going to try to get up and go get it on their own. Yeah. We want the patients engaged. We want them to be a participant that's active, literally and figuratively active with this, because we want them to use their mobility device, and we want them to be able to get up and get out of bed, and if they can safely get to the bathroom, we want them to be able to do that. But almost 50% of institutional falls occur around the bathroom issue, and about 20% of those falls occur because they're trying to get from the chair to the bed, or the bed to the chair, or the toilet to the bed. So a high rate of falls surround the bathroom and surround transfer.
So just think about that. If we really emphasize bathroom, safety for the bathroom, to make sure that we're doing, constant education on toileting, and to the staff to make sure that they are engaged, as well as helping them with transfer the bed, you would help 70% of the falls.
It'd be a bunch. It would be significant.
I mean, it would really be significant.
So after a fall has occurred, we have kind of like a whole series of things that we need to do. We need to evaluate completely, thoroughly evaluate the patient for injury. And they need not just a reassessment of them physically, but we need a reassessment of their skills and their abilities. So we want those people to be mobile. We want to get them mobile early, and we want to have them be mobile often, and we want to be able to deliver that care. The nurse has to be able to document the information related to the fall, and we need to be able to communicate that information to the other staff that are also caring for that patient.
Right. Especially if they're, and if there's environmental circumstances that cause the fall, or other issues like that, we need to remove them from the equation. We need to report these falls to leadership. They eventually go to the fall champion, which then will report it to leadership. And then we were very proactive on trying to figure out ways to have prevented the fall, kind of like a Monday morning quarterback. Let's try to work together and look at, okay, XYZ fell, let's see what we could have done better.
And they need a lot of data. And
Yeah.
I think that kind of information you don't get from click boxes. You get that from historical information.
Writing.
There is a kind of several phases of a fall. And, phase one is where the body gravity is off, the center of gravity changes, and maybe a joint issue, maybe the weakness, maybe the reflexes aren't right, but that's where the phase one is. Then phase two of the fall is the body can't or doesn't correct itself quickly enough. Phase three is the impact. And then phase four is what's the result of that fall? What happened to the individual because of the fall?
And like we've said earlier, sometimes you don't know the result quickly. It may take 24 to 48 hours to see the impact, especially if there was a neurological event that occurred. So it's really important to constantly reassess the patient.
Sitters, nor alarms prevent falls. The sitter and the alarm may tell you what's happening, but they don't really prevent it. And grab bars have variable data. Sometimes grab bars, the patient can actually get tangled up in the grab bar, or the patient can actually get injured by the grab bar on the way down.
So grab bars are kind of a necessary event for some people because patients won't get up without them, but then we also have to know that they can cause trauma.
We've seen some interest in video surveillance, but that opens up a whole nother issue of patient confidentiality, patient privacy, So, surveillance would be good because you could see the patient swinging their legs to try to get out of bed, but then the patient doesn't have that privacy. So there's a lot of things to be worked out about the surveillance.
At patients' homes, a lot of them now have the video monitor instead of just the regular baby monitor, which was audio only. That's a little different when you're in a home setting, but
like that's their own family.
Yeah. But like Dr. Bohn said, in a hospital setting, there's a fine line. So we'll see where that goes.
We'll see where that heads over time. The big thing is to get patients moving safely in an institution, get them up and get them going early and often and in a safe manner. I call it the princess effect, because everything comes to me when I'm at the hospital. I lay in my room and they bring me something to drink. I lay in my bed and someone brings me something to eat. I push a button and they bring me, whatever I need next. I push a button and the television comes on. And that's not what we want people to be doing. We want people to be active in a safe manner.
Yeah, and what better place to do that is in a hospital setting where you're monitored, so if something happens, you can get care immediately. It's somewhat safer than maybe your home environment, and there's professionals there to help you. So oftentimes we'll have patients that end up in the hospital, unfortunately, because caregiver burnout. I mean, they might just go there because they're declining, they'll go there for caregiver burnout, and then those patients sit, as Dr. Bohn says, as a princess or a prince effect, wanting everything handed to them, and then it's dated discharge, and you look back and you're like, oh, they haven't even been out of bed. What? Like, how are they going to go home?
It's not a good thing to be in the hospital because of things that we talked about before, risks of exposure to infections and falls, increase of morbidity, mortality, your functional decline, and if you decline functionally, it's possible you may not recover to your prior level, and it could result in permanent institutionalization. So we want people to be safe, we want them to be active, we want them to be mobile. We don't want falls, whether they're in a home, and certainly we don't want falls in a hospital or in an institution.
Yeah. And I feel that in the hospital institution, that's the one place, the 3 or 4 set places where we can actually have a little bit more control over them and set better guidelines and look at it. It's related to, moving your bowels or urinating. So that will prevent 50% of your falls. And then transferring. These are common activities of daily living that we should be able to have control over.
So that's how we find falls to fit into that serious illness category and why falls are so significant.
We hope that this video did cover a lot of information. We hope that we'll stop pointing fingers at, oh, the nurse made my father fall, or the doctor was ignoring my mother and asked to repeat the whole history. Let's stop pointing fingers. Let's in 2023 start moving forward of how we can all take an active approach, a team approach to prevent falls from your loved ones so we can keep them around a lot longer.
I agree. Let's move forward and let's deliver better care.
Yes. Thank you for joining us.
Thank you.
We'll see you next time.